Hello, everybody, and welcome to Transaid's webinar today. We are just going to wait for a minute or so just to allow a couple of last people to join, and then we will start into the presentations with all of our colleagues who have joined from the different organizations from this webinar on improving access to health in Nigeria through emergency transport schemes. So if you'll just bear with us for 30 seconds to allow the last couple of people to join in. Thank you. Okay, thank you everybody for joining today. So before we start, I'm just going to give a quick run through of some of the housekeeping for today. So by all means, please feel free to provide questions throughout the whole webinar, and you can do so by typing your questions in the question function. This will either be in the format of a question mark or a little speech bubble, depending on what piece of software that you are using. You type in your answer and then you click the send button. If you hit return or enter, generally the questions do not send through. So there's a question function somewhere on your dashboard that is either in the form of a question mark or a speech bubble. And if you click on that, you will be able to enter a question and then click the send button and it will come through to us here. Apart from that, we have a couple of different presenters today. We are still trying to get one through, so hopefully he will be able to join before it comes to his presentation. Apart from that, hopefully you're able to see all of our different participants today who will be presenting. Ishmael Balogun, who's a national consultant in Transaid, has worked with for a number of years. We hopefully will be able to get Farouk Yusuf from Society for Family Health, although he is currently having some technical difficulties. Ahmed Haliru from Chai in Nigeria, and also in Nigeria from IHP, we have Usman Al-Rashid and Ibrahim Kabo. And myself, my name is Edward O'Connor, and I'm the Programs Support Manager for Transaid. For those of you who don't know, we're an international development organization who specialize in transport and logistics under the themes of access to health and road safety and driver training. So without further ado, I'd like to introduce my colleague who is going to start today, Balogun. Please take it away.
Good morning, everybody, panelists and attendees. My name is Ismaila Ali Balogun, Transaid National Project Manager and the Pioneer Nigerian Consultant on Emergency Transport. Next slide. What is emergency transport scheme? Emergency transport scheme is service provided by volunteer commercial drivers and motorcycle riders, all of whom belong to transport unions, particularly the National Union of Road Transport Workers, popularly called NURTW. It is a public-private partnership collaboration on referral between the union and relevant government agencies, designed for the timely transfer of pregnant women experiencing maternal complications, particularly in rural communities, to the nearest health facility, offering basic or comprehensive emergency obstetric care. Next slide. How did ETS start in Nigeria? Jigawa State in northwest Nigeria was one of the states with the highest maternal mortality and in response, a thorough analysis of the situation revealed The access to health facilities was a major factor contributing to women's inability to access maternal care. NURTW, having held meeting with the Ministry for Women Affairs, Partnership for Transforming Health System, and the consultants agreed to sensitize and engage the services of volunteer drivers to commence transporting pregnant women to health facilities at no cost. Appropriate programs were designed to actualize this plan. Next slide. In order to be able to build the capacity of the volunteer drivers, a training manual that contains 16 chapters or sessions was created with inputs from NURTW, relevant key stakeholders, and subsequently approved by the National Union of Road Transport Workers president in 2012. It was designed to serve as the official document for developing the capacity of master trainers and volunteer drivers. We needed an evidence-based information, and we went designing data capturing documents, data collection process. Drivers carry an ETS logbook, which records dates, name of patient, community, facility transported to, LGA, time of trip, and a few other vital information. The recent log sheets also includes maternal danger signs. The logbooks are signed by the Ministry of Health workers at the health facility. The driver then takes the logbook to the motor park, where the NURTW officer in charge at the motor park collects the patient data into a master table. This is forwarded usually to the national headquarters of NURTW. Next slide. In the implementation of ETS, in the design of ETS, it was agreed during the right from when ETS was starting in 2005 that it should be a process, not anybody just jumping into the field, into a state and say we want to start ETS. We therefore did quite a lot of meetings with the drivers, with every stakeholders, with research organizations, and brought forth our experiences. And below are the example of phases that were designed to be able to implement ETS seamlessly. Starting with situational analysis, or what we call formative research. We do baseline studies, select communities that have high cases of maternal mortality, sensitization of community leaders, drivers, religious bodies. Then we now select and train NURTW state officers as ETS trainers or facilitators. We work with these trainers, these officers, to select volunteer drivers at communities. Then after that, step-down training is done using the NURTW trainers. Then immediately after the training of the volunteer drivers, ETS activities commence. And then data collection, reporting, supportive supervision continue to, visitation to communities, health facility sensitization, and other activities follow. Then within the period, within the period of the exercise implementation, midline studies and endline studies are usually conducted and strongly recommended, because that will usually give us the opportunity to know what has happened within the past 6 months, what has happened within the past 1 year, what has happened since the 2-3 years that, and so on, that the activities started, the challenges, the successes, the outputs, and the results. Next slide. Summary and conclusion. ETS has been and is still being implemented in Nigeria by a number of partners. Reports from intervention communities, drivers, and health providers suggest that lives have been saved. In fact, thousands of lives have been saved. Even as you and I are here now, our volunteer drivers are still helping to support our rural communities in saving the lives of thousands of pregnant women as a result of ETS and other medical interventions at community level. The NURTW, which is the key implementing partner, has very strong committed leadership and has demonstrated its support to the success of the scheme across the country. And we've had a lot of good stories about their activities by other partners. Investing adequate time and resources in situational analysis and design work, paying particular attention to social and cultural traditions, implementation and refined methodologies and tools, and working flexibly and opportunistically all contributed to effective success of ETS. This is very, very, very important, because what we're saying is that no matter what you do, if we don't invest adequate time and resources to situational analysis to know what was going on before the commencement of ETS, and we don't invest enough time for design work, it's likely to have problems. So the emphasis is usually placed on this. Next slide. Among the challenges in the implementation of the system include weak monitoring and evaluation system, inadequate data collection machinery, difficult terrain, and the health workers who are not brought fully into the system as key stakeholders. Some of them feel alienated. Some of them believe that, oh, the drivers, how can a driver use his commercial vehicle and then will not collect money? So they have that misconception. So we have a duty to make sure that we continue to create awareness in them that this is social responsibility by the NURTW and by your organization to give back to the community. So the health facility workers will now reasonably cooperate with the system. The challenges posed by COVID-19 and lockdowns all impact the delivery of health services. ETS is no different, and all due care must be taken when ETS vehicles are able to operate. International guidelines on person-to-person contact maintained, cleaning system adhered to, PPE and other precautionary efforts must be adhered to in implementing ETS during this COVID-19 and beyond. Frontline workers are key, and the risks to them must be reduced. With the frontline workers we are talking about are the health officers, including our drivers. Our drivers are very strong frontline workers. So we should ensure that the risks attendant as a result of COVID is ameliorated as much as possible. Thank you very much. Thank you for your attention. There's so much that would have said about ETS, particularly by me as the pioneer consultant, but time is not much enough. We hope we'll have another better opportunity in future. Thank you very much for your attention.
All right. Thank you very much.
I want to hand over to Farouk Yusuf from Society for Family Health. Farouk Yusuf, please.
All right. Thank you, Mr. Balogun. Good afternoon, everyone. My name is Farouk Musa. I work with the Society for Family Health Nigeria, and I'll be sharing some of our experiences implementing the ETS scheme specifically in northern Nigerian states. Next slide, please. Yeah, by way of introduction, SFH is an indigenous Nigerian NGO. Our mission is to empower Nigerians, particularly the poor and the vulnerable, to lead healthier lives. Like I said earlier on, my presentation is actually going to be in retrospect, talking about some of the ETS schemes we have implemented in the past. Currently, we're running a new project, the LAPIA project. We also have ETS on it, but we are still at the inception phase. And so my discussion here will center around most of the things we've done in terms of implementation of ETS in the past 6-7 years in some key northern Nigerian states. Next slide. Yeah, I heard Balogun talk about some of these approaches, training of master trainers, and some of the garage mobilizations and all of that. So I don't have to dwell on this, but again, it's very key to say that capacity building cannot be overemphasized, because the drivers will have to be, their capacity has to be built for them to be able to run with the scheme as it is. Lifting, the picture you can see here is one of the trainings that is happening. That was in Zamfara State. And I think importantly for us, we have been able to work very closely with the National Union of Road Transport Workers. We allow them to lead, to coordinate, and also to provide the technical support that is required in implementing most of the ETS scheme in our state. Just to mention that we've implemented in like about 8-9 states, like 3 northeastern states, and also most of the states were in the northern, north central states. Between 2015 and 2018, we've successfully transported women with pregnancy-related complications to the tune of over 126,000 women. Next slide, please. Yeah, our approach. We ensure that as much as possible, you can't separate the scheme from the community, and so we try as much as possible to weave the systems within the systems of the community. And then what that simply means to us is the entry point, the supervision, the support that is needed, the selection of the volunteer drivers is actually driven through the NUR3, but of course the ward development committees, because of course you don't have the structures of the NURT within every community, but we have the ward development committee, which is a group of persons within the committee that within the community that are responsible and mandated to look after developmental issues, health of course inclusive. And so we go through the WDCs, and then also work very closely with the facilities within the community. The service providers are also trained, they are part of the system. During what we call the review meetings, quarterly review meetings, as a matter of fact, it's the facility staffs that actually, either the health educator or the OIC, the review meetings, suffice to say, that happens within the facilities, where we bring everybody together to get to hear what happened in the last quarter and then review the data and all of that. And then that also means that we're also handing on skills to the community. And of course, by doing so, we've been able to, during that period, because of the successes we recorded in our state, we had new stream of ETS come up. Of course, we started with, the focus was more with NURTW, and then we're using vehicles, cars, and all of that, buses and all of that. But again, before the projects I mentioned ended, we had the Association of Tricycle Riders come in, and then they came in. It was really very useful because we had places where cars cannot go in. It may not be the best in terms of convenience, but at least they also came on board. And then the beauty about it, the NURTW was responsible for training them and handing over most of the skills to this group of persons. And of course, the community ETS, where we also had community members volunteering their private vehicles A case in time is in Gombe State, where you have private persons giving their numbers to community members. If we have emergencies, give us a call, and then they came out. And of course, this was because they saw what was happening in the system in terms of ETS. And then I've mentioned the issue of NRTW being secretariat for training faculty. As we're going into our new project now, there's no doubt we're going to be working very closely with NRTW, and then we have a lot of skills and competencies seated there. And so the trainings and all of that, because they've been able to, the sustainability and the transition has been very successful. We hope that in this our new project, we're going to work again very closely because we have the skills seated there to do that. Next. And Mr. Balogun had also talked about the data collection processes. I don't have to dwell so much on this. I've talked about the joint quarterly review meetings that we have. Just to mention that the picture you see here, because of course most of the drivers are not literate, and so we develop low literate materials in such a way that they can just, we have tallies where they can just tick or cancel to show the activity that was carried out. Just to say that at the facility level, we have a section where the providers also sign to testify that yes, this driver came in so time, and that. Let's move on. Next. Yeah, in terms of sustainability, I think this is very important because we notice that most of the ETS scheme mostly driven by partners, donor partners. But what we tried to do was to ensure that government was taking responsibility. And then the sawmill, which is a government initiative, the Saving 1 Million Lives, a lot of monies were invested through the Saving 1 Million Lives, where they trained more. Of course, our resources as a program couldn't cover all of the look and cry needs of the states. For instance, a point in time is also Yobe and Jigawa, where we have the Saving 1 Million Life supporting trainings, putting in resources and equipment, printing manuals, printing, basically putting resources to ensure that we scale up the ETS across the state. And then again, we, as much as possible before we left, we ensure that we identified institutional homes for the ETS. In most of the states, of course, it was seated with the primary healthcare development agencies. But the beauty about the sustainability and also working closely with government was in most of the states, we ensured that we had budgets for ETS captured in the state annual operational plans. That is more sustainable to us than programs that come and go. And then I've talked about the community ETS. Of course, I've also talked about the last slide. Next slide. Yeah, some of the lessons. Integration of the ETS strategy into the local, I've mentioned this also. And then again, the ETS wouldn't work in isolation. And so all of the time you're implementing the ETS, it happens within the community. You have to identify relevant structures to support the running of the ETS. A very good example is the TBE. In our case, we have the TBEs working very closely. They have the numbers of the ETS drivers within their clusters, and then they give a call when when there's a distress call. The TBEs come in, and then they get in touch with the ETS driver. And of course, the religious leaders, that can be overemphasized. Working very closely with the religious leaders, we ensured that we had a joint review meeting. The religious leaders are there, traditional leaders are there, the TBEs are there, and so it becomes like a community thing. Everybody knows what is happening, and everybody knows the benefit of it. And then, of course, another lesson is the free nature of ETS has direct impact on encouraging more pregnant women to be part of it. Of course, you know you're not paying, and then there's a support from the community and to lift you, to transport you to the facility. And so that also gives a sense of confidence within the women that if they have issues, there are vehicles that can actually move them to the facility. Considering the fact that most of the populace, we have them residing within the core communities, hard to reach areas, and all of that. Next. Yeah, challenges. Poor facility level staff attitude to data management. I think Mr. Balogun has also mentioned this. And of course, we can't blame it so much on the facility staff. We know that in terms of human resources, we have issues within, especially at the PhD level, we don't have. And these are people that are managing so many data for so many programs. And so there are issues in terms of keeping data and also recording. There are periods where you have the drivers come in and then the women are taken care of, and without even the providers within the facility actually making an entry into the books that they have in the facility. And of course, security challenge also hinders this, especially in the northeast and also part of Kaduna. There are periods that we had to suspend the scheme in security tight areas because firstly, there are lots of curfews. Secondly, deliveries, mostly labor, happen in the night, and then all of that. So that also brought some numbers down in terms of what we get on monthly and quarterly basis. And then there seems to be some level of political interference in some states where we find it because of the successes. And so you find politicians trying to hijack. And then there's a conflict between the supervising ministries, the MDs, the NURTW, and the politicians. And then, of course, utilization of data by government. I think this is very, very key. In all of what we do, I think the government needs to, in terms of utilization, I don't think the government is doing enough. How much of the data is being used? How much of the data is being used by government in planning, etc. Next slide. Yeah, these are just the next two slides are just pictures for you to see. The guy in T-shirt is an ETS driver. That's the nurse that delivered these twins by the right, and then the mother in the middle. The guy in the right is our staff, and then that's the ETS driver that got that call, the distress call, and then supported this woman to have this baby. This in Kaduna State. The next picture is in Jigawa State. Aha, this is another driver that had closed from work and he met this lady. That's Jigawa State. She's a Fulani woman in distress. Also, she was actually bleeding on the main road with the husband. He stopped over, supported, took them to the facility. The woman delivered safely in the facility. Just to say that this driver got an award from DFID and also some sort of award from the present state governor of Jigawa State. So I think this is my last slide. Over to Ahmed of Chai.
All right, thank you, Farouk. As the earlier presenter mentioned, my name is Ahmed Hanuru. I will be presenting on behalf of Clinton Health Access Initiative. So I'll be sharing our experience in our effort to scale and sustain ETS activities in 3 northern states of Kaduna, Kano, and Katsina. Next. So as way of background, CHA implemented a comprehensive maternal and newborn health program from 2015 to 2016. And one of the core pillars of that maternal and newborn health program is the emergency transport system. So we work towards expanding and also scaling up ETS program within Katsina, Kano, and Kaduna states. To do that, we focus initially on the first 30 LGAs, 10 each from the 3 states. And these LGAs were selected based on the high burden of maternal mortalities. And in that process, we engage and partner with over 2,000 NURTW volunteer drivers and officials, as well as nearly 600 motorbike tricycle operators, volunteers also from these 30 LGAs. In addition to the partnership, we also procured and distributed 250 motorbike ambulances to the National Association of Tricycle Operators and Owners in Nigeria for these respective states. In 2016, we scale up the services for ETS to also include postpartum family planning within the first 48 hours of delivery. This was also part of the project we're working on as part of comprehensive maternal and newborn health program. In 2017, we commenced joint government and community engagement to sustain the ETS, also conduct the first round of refresher trainings to all the volunteers within the 30 LGAs. In 2018, following the sustained advocacies and engagement, we're able to secure high-level commitment from the respective communities, the local government authorities, to be able to make a monthly contribution to sustain and maintain the motorbike ambulances. The same 2018, we also organized a recognition and certification award presentation to high-performing volunteers. In 2019, looking at the successes recorded in the previous years, we first fully handed over the ownership and the full maintenance responsibility of the ETS to the various communities and the health facilities. In addition to this, we also scale up the ETS support across the entire program states, bringing in additional 68 local government areas. Next. How do we approach the implementation strategies? We engage a comprehensive approach, leveraging on existing structures within the government, communities, and trade unions, associations. As I mentioned, AURTW, the NACTOMORAs were essential to the ETS implementation. First, we took the approach through the system strengthening, where we ensured that any existing referral protocol is actually revisited to incorporate the ETS. For states where those referral protocols were not in existence, we were able to support the government to support the referral protocol. We also ensure community and facility linkages across all the facilities and the communities that we supported. We also expanded the responsibilities of the government referral focal persons to also include ETS activities. In terms of capacity building, as I mentioned, we train a number of NURTW and NACTOMORAs volunteers and officials, as well as within the government, a number of government senior level officers, as well as the ETS and the referral focal persons at the state and the LGA level were also part of the training. Of course, advocacy is key, especially to gaining buy-in as well as sustainability. At the level of trade unions, the NURTW, there were a very high level advocacy visit at the national level. And this advocacy was actually to key into the existing NURTW program of reaching every ward, every LGA, every ward expansion program for the ETS. We also continue to advocate for the inclusion of ETS activities as highlighted by the earlier presenters. Most of these states, ETS now is put as part and parcel of government annual fiscal plan for health interventions. Community-wise, we did a number of community engagement, and these are all around taking ownership, taking responsibility, as well as for communities to begin to recognize the contribution of the ETS volunteers as part of the comprehensive healthcare system. As mentioned earlier by the presenter, data visibility actually was one of the key limiting steps at the initial onset of the ETS program. In particular, within the government sectors, there is lack of adequate visibility for what the ETS is doing. To address this, we actually engage government to ensure that ETS is part of the points and topics being discussed at all the relevant technical working group discussions at the state level, and also ensure that there is an online ETS dashboard that is accessible and improve the visibility, which also improve the visibility of ETS activities. Next slide. So this highlights some of the key results in terms of overall number of women that benefited from the ETS program. And looking at this data, you observe that more than 50,000 of the women transported were actually from the NURTW volunteers, whereas about 40,000 were transported by the tricycle operators volunteers in the communities. Next slide. So we'll now talk about sustainability strategies that were actually employed across the 3 states to ensure that ETS have come to stay and is fully recognized as a part and parcel of the healthcare delivery system at the primary healthcare level. The first approach was to strengthen communications between communities, the community change agents, as mentioned, people like the traditional birth attendants, the ETS volunteers themselves, and then the healthcare service providers. We did this through the provision of closed user group mobile phones, such that communication is actually seamless between these community change agents. The issue of ownership, as I highlighted earlier, was very central, and we ensure that we get government to actually dedicate funding towards supporting ETS activities. The use of data was very key. And one very important sustainability strategy was the knowledge management. So you realize that across all the states where ETS is being implemented, there is a pool of very strong and capable trainers, especially within the NURTW and then at Tomaras, both at the state and the LGA level, that have very strong knowledge and background in the ETS and are capable of actually cascading the training to more volunteers that are willing to go into the scheme. Funding actually is key to sustainability, and to do this, as I mentioned, we leverage on the annual operational plans, and specifically in Katsina, we followed up with the government to earmark a funding from Basic Healthcare Provision Fund that goes directly into the health facilities at the PSC level for a dedicated amount to be used in supporting ETS volunteers in such communities. Next slide. As typical with every program implementation, there are some key challenges actually that were encountered. We'll just highlight especially some challenges around sustainability of the project or the program, lack of proper commitment of the community at the initial onset, and this is what actually prompted in 2017 for us to work with the government and other trade unions to sustain advocacies at the community level, and eventually we're able to get the communities to be able to commit certain amount of money on a monthly basis to be able to cater for the volunteers in terms of a little motivation, as well as routine maintenance of the MBAs they were giving to the communities. From the government point of view also, we had a number of engagement with the government, as I mentioned, where eventually in Katsina we're able to get funds from Basic Healthcare Provision Fund assigned to taking care of PSC referral activities. As I mentioned, lack of visibility was also one of the key challenges we identified in the terms of government level visibility. And one of the key strategies was to ensure that ETS is part of the discussions among all the other key intervention areas in maternal and newborn health program. ETS should also have the same visibility as other intervention areas. We also supported all the states where we work to ensure that there is a real-time data visibility across the state level in terms of deployment of the online dashboard, where critical stakeholders at the state level have access to some of the core data indicators within the ETS program activities. So this is what we have to share as part of our lessons learned from the ETS program support in the 3 states I mentioned. So at this time, I would like to call on fellow panelists, Usman and Ibrahim from IHP, to give us their presentation. Thank you.
Yeah, thank you very much, Ahmed Khaliru. Morning, ladies and gentlemen. This is IHP. IHP, it's an integrated health program funded by USAID. It's an PRRINN-MNCH project. and also a health system strengthening aspect of the project. It's a task order program, 5 to 7 years, funded by USAID, like I did mention, in 5 states and the Abuja Central Office. Ladies and gentlemen, this is a 2-part presentation. I'll be talking on the first part, the emergency transport system in Sokoto State, while Kobo will give an update on Bauchi State. Next slide. Thank you. Yeah, in Sokoto State, as far back as 2017, the state government had planned for an emergency transport system where 300 4-wheel drive ambulances were procured by the state. 244 of those ambulances were distributed to the 244 PHCs across the 244 wards in the 23 LGAs of the state. Again, the overall objective then was how can the emergency transport system begin to reverse some of the high incidences of the maternal newborn child health indices in the state, and then trying to look at breaking the barriers between the supply side and the demand side and improving the referral system. So there was a high government commitment in reversing the high maternal newborn and child health indices as a priority agenda for the state. Next slide. And so the State Ministry of Health, alongside the State Primary Healthcare Development Agency, did a situational assessment of the emergency transport system in November last year, 2019, to find out the functionalities of those ambulances, how many of the ambulances were adequately equipped to provide basic ambulance services, the skills of the ambulance drivers, the functionality of the communication equipment within some of those ambulances, as well as the support staff that accompany those ambulances. So the states did that in 2019. And on the right side is this is the situation of some of those ambulances. We'll get to talk about this later. Next slide. Thank you. Next slide. Yeah. So what's the outcome of the assessment? Again, one of the things that we found out was that there is a high level commitment on the part of government to improving referral and addressing some of those barriers to accessing care services in the state. For having gone to procure 300 ambulances for 244 LG PHCs in 244 wards spread across the state. There was some level, for some LGAs, there were level of community ownership because they were contributing to maintaining the ambulances located in the communities. This was particularly so with the efforts of the ward development committees. In Gada, the committees there were very functional. In Rapa local government, in Alakiru, they were very functional and they were providing resources for the maintenance of those ambulances, as well as in Sabon-Burni local government. However, there were low capacities within the health system of the state to be able to manage the emergency transport services and referral. At a point, as at end of October, only 84 of the 244 ambulances were functional. And if you look at the trajectory of the functionality of the ambulances, it started with 244 ambulances. Last year, there were 166, and then now it's 84 functional ambulances. Most of the ambulances had no essential resuscitation kit or first aid equipment in them. The drivers were not even trained, and the healthcare workers, no support staff on the ambulances to provide some level of first aid while on transit. Next slide. Thank you. So looking forward, what we are doing is that IHP is providing support to the state. A well-expanded state steering committee has been established, comprising the police, the federal road safety, traditional and religious leaders, WDC's member, NURTW, the road transport workers, other development partners, to see how we can provide a back-end technical support to the state emergency transport services so that most of these ambulances can be up and running again. We also developing a standard operating procedure that will be low literate for all the employees and volunteers of the state emergency transport scheme and referral services. In addition, we will support the capacity building of the volunteers. We're working very closely. An assistant commissioner of police is assigned by the police command to be part of the steering committee. And then how do we leverage on the NURTW skills in providing quick response in communities where it's inaccessible, particularly how to reach communities where you have high levels of banditry or terrorism, cattle rustling, and it will interest you to note that emergency transport services is also part of the life-saving tools that we need to bring on board. And that's why that takes me to the last point, that it's quite exciting to note that 5% of the basic healthcare provision, it's now made available for emergency medical treatment, which really looks at including ambulance services. And I think if this is done, it's really going to take our life-saving skills to the next level, because anybody who needs emergency medical care can quickly call the toll-free number or a CUG number, and then you get emergency response. Whether the vulnerable population, pregnant women or children under 5, you'll be able to access a quick response services, particularly so in terms of epidemic like coronavirus. This would have been very, very helpful because of the time lag between when the symptoms begin to manifest and when you get a response. I think these are situations where we begin to now, as a developing country, begin to address emergency medical transport for all Nigerians. Next slide. Thank you. I now call on Dr. Kabu of IHP Bauchi to take over from there. Thank you very much.
Okay, thank you so much, Usman, and good morning, good afternoon, ladies and gentlemen. As Usman said, that IHP is being implemented in 5 states in Nigeria, and the 3 major objectives, apart from the health system strengthening he made mention, is improving access and increasing quality of primary health care services, which make emergency transport system a very important component. Next slide, please. Yeah, so Bauchi, situated in the northeast Nigeria, has an estimated population of 7.6 million. Currently has a state referral policy in a draft form, as well as the training manual for emergency transport system. The beneficiaries, as the other panelists made mention, are mostly women and children under the age of 5. The key actors in the states are the Ward Development Committees, the National Union of Road Transport Workers, and the Motorcycle Riders Association, as well as the community-based health volunteers and health workers. And there are ambulances that are available in most of the general hospitals and some PSCs in the state. Next slide, please. Yeah, so in Bauchi State, there are largely 3 distinct systems or components, if you wish, for referral that are identified. One is the emergency transport teams, then emergency transport fund, and then emergency transport system. Next slide, please. Yeah, so the emergency transport teams in Bauchi are largely a group of community individuals who volunteer their personal vehicles or means of transportation free of charge. These individuals are largely identified by the ward development committees, and they are linked up with appropriate cadres or structures, including the community-based health volunteers and other community structures, including health facilities. However, in this particular system or approach, the family member or the WDC takes over the cost for fueling only, while the driver volunteers the vehicle or that means of transportation. Next slide, please. Then we have the emergency transport fund. This largely represents a dedicated fund that is set aside by committees through the ward development committees. In this aspect, these funds are raised either through donation from philanthropists or profits that are made from the drug revolving fund scheme activities. And also there are sometimes or in most instances contributions from the members of the WDC that are equally included in the basket. So in this particular kind of aspect, there are no drivers that were or are identified and saddled with responsibilities of conveying those clients that need kind of emergency referral. However, any convenient means of transport is used and the cost is paid from the fund. Next slide, please. Then you have the emergency transport system. This, as previous speakers mentioned, involves partnership between the communities through the ward development committees and the unions. However, it is worthy to note, I made mention earlier, that the functionality of a ward development committee largely determines the functionality of the emergency transport system within. And here, those drivers that are eligible are usually identified by the WDCs as well as the unions, using a set of selection criteria, and they are trained and properly linked with the relevant structures to ensure effective and efficient kind of transportation of those that are in need to nearby facilities. Next slide, please. Yeah. So in Bauchi, currently there are two types of ETS, if you may. One is the one that is led by the government using specialized ambulances, as Usman made mention, most largely in general hospitals or the secondary care facilities, as well as some select of primary health care centers. And then the community owned. Here, there is the ETS that is owned and driven by the WDC, where the vehicles or any means of communication is acquired through advocacy or is purchased by the WDC itself. So you can see here there are some various modes of transportation, including the car, tricycle, motorcycle, or even cattle cart. And then the other one is the one that I made mention earlier, that there's a kind of partnership with those unions, the NURTW and the ACOMORA. Next slide, please. Yeah, so this some of the pictures where those tricyclists are used to kind of convey those in need to nearby facilities. Next slide, please. Yeah, so what are the plans for kind of strengthening emergency transport system in the state? One is that series of technical consultations on referral and emergency transport system. This is with a view to establish, those models that exist and are working efficiently and effectively. So, and also to recommend, to review the referral and emergency transport guidelines in the state, which IEP is instrumental to that. Other thing is including or incorporating the mobile referral, which is quite important in those in the review of those guidelines, and expand the scope of key stakeholders involved, and then to continue to engage the world development communities in terms of either reactivation or strengthening them. As I said, that they play an important role and also ensure journey to self-reliance, capacity building activities, mobilization of additional support, as well as incorporation of ETS into the state reproductive maternal newborn child intervention platforms, and include data generated into existing state program data monitoring for action, which is quite key and which is also an area that is quite weak, and that will inform how the states will use different kind of funding streams to be able to support this kind of system. Next. Yes, I thank you so much for your attention, and I would like to hand you over to Edward for kind of subsequent proceedings. Thank you so much.
Thank you very much, Ibrahim. So just to finish off all the wonderful presentations that we've had today, I just want to touch a little bit on some evidence, some surveys and some evaluations. We've heard all about the processes and how things are moving forward and how the future is looking. But a big part of this is always looking at data and information. So just to quickly touch on some information that we've gathered as Transaid through some of the projects that we've worked on. And you can see here that from some ETS user surveys, we found out that a lot of the women who are using ETS are suffering from complications, or what they class as complications, which shows that ETS is really answering an issue that is out there for women in Nigeria. We can also see that 97% of ETS cases take under 30 minutes to travel to a health facility, is under 30 minutes as well. If you compare that with non-ETS, which is only 56% and 41%, it really shows how quickly well-trained ETS drivers are responding, and we know how vital that first hour is within a maternal emergency. We've heard that as well, that ETS is generally a free service for the most part, and that only 3% of women asked were required to pay a fare, and a majority of the time that is just looking for fuel money versus overcharging during an emergency, which is one of the issues that ETS is trying to combat. Versus that with non-ETS modes of transport, where almost 90% of women have to pay immediately or upfront. And this is one of those barriers that ETS is trying to overcome, of the finance issue, but also having to come up with the payment for a fare immediately before the service is even given. And the majority of women who came to know about ETS was through family member and ETS, NURTW driver, health facility, and none have reported dissatisfaction during that survey. This is important because it touches back on what everybody has been talking about the links to communities, sensitization, engaging in stakeholders. This is how the communities not only find out about ETS, but trust ETS. We were also fortunate enough as Transaid to be able to conduct a health facility study, and this study looked at the health condition of women who were arriving at health facilities. And it showed statistically that ETS users arrive at a health facility in a better health condition than those who use any other mode of transport. So this really shows the impact that ETS is having by getting women to a health facility once they've made that decision in a better health condition because they are arriving quickly. Women who use ETS are poorer in general than those who use other modes of transport. Again, this is what ETS is there for. It's to try and get those who can no otherwise normally use transport to get to a health facility to have the option to use it and be able to make those informed decisions. Health conditions, so ETS and non-ETS, were varied significantly, but contributing factors were distances, but also delays due to decision making, which I've already mentioned. If women know about ETS, that will improve their decision making process because they know they can access it quickly and it's affordable and it's safe. And ETS users organize and reach a health facility within 1 hour. This verifies the information that we are finding out through the face-to-face surveys that were carried out a couple of years ago with ETS users. And finally, just to touch on, as an organization, Transaid are very much on top of looking at how the work that we are doing is making an impact, and also to try and ensure that what we are doing is meeting the needs of what we want it to. So we are very much behind activities such as external evaluations. And I won't read through everything here, but it does show some interesting insights into the work that we were doing, particularly with Society for Family Health in Adamawa State in the east of Nigeria, funded through Comic Relief. And this showed that ETS most likely contributed to the reduction in MMR within the state, along with, as others have mentioned, other health activities. And the recording system was used was highly accurate, and that factors that had significant bearing on the project's success were building on existing infrastructures, the selection of the right types of drivers, and that volunteerism was anchored on faith and goodwill, and ETS service was provided for free. All of topics that we've touched on, but having these pieces of information that link into external evaluations and surveys really drive home what ETS is doing and the reach and the scope of ETS. And then just in conclusion, I just wanted to touch on the fact that ETS is in Nigeria. It's been operating for over a decade. There is statistical information out there. It can be used to help with proposals, to go to policymakers to help them move forward at a state and national level. Transaid on our Knowledge Centre has all this information, and I'm quite happy to share it. Nigeria can strive to have ETS nationwide in all of its different types and forms. And the government, the Ministry of Health, the NURTW and stakeholders all have parts to play in this. It's very much a combined effort to move ETS in all of its forms forward. COVID, of course, has been talked about a little bit as well, and that has brought new challenges to all health systems globally. Lockdowns, reliable information, PPE, procedures all play a role in how healthcare is delivered now and in the future. And that has been mentioned already, should be looked at and should be planned into the future as well. Thank you very much, and thank you to all of our panelists today for their very interesting presentations. We have got some questions that have been sent in throughout the presentations. So I'm just going to go through a couple of them now and give them out to some of our presenters who can answer these. So first off, we would like a question for Balogun. So Balogun, the question is, how common is it for private vehicles to be used to transport patients in Nigeria?
Come up again.
How common is it for private vehicles to be used to transport patients in Nigeria?
Yeah, thank you very much. In urban or semi-urban areas, it's quite common for private vehicles to be used to transport patients to health facilities, particularly pregnant women. The next door neighbor is ready and usually willing with his or her private vehicle to come to the aid of a pregnant woman in labor, particularly in the urban and semi-urban, peri-urban settlements. It's not very common in the rural areas because of lack of vehicles, private vehicles.
Okay. So this is open slightly further to anybody who is willing to jump in. Although the ETS launched with a focus on urgent maternal care, has the project teams become aware of other needs and other urgent medical needs and complications? So outside of maternal usage, maternal care, has anybody within your projects come across the need for ETS or the usage of ETS for other healthcare purposes? So please, anybody feel free to jump in.
Hello. Okay, I think yes, I will want to share a little bit of insight into that. I know, yes, especially for us, for most of us, because we are essentially working towards improvement of maternal health care. That is why we tend to be biased towards that. But in real sense, actually, these emergency volunteers in terms of their training, they are even being provided with essential life saving skills in terms of CPD resuscitations, and even trainings in terms of how to properly handle patients, in terms of lifting of patients that is in emergency situation, for instance, accidents and the rest. And then also, like when the IHP team were mentioning, especially police officers and federal road safety are part of the integrated ETS approach, where they collaborate with these drivers to fast track transportation of accident victims, especially from rural communities. And I think these are more some of the more critical other uses of ETS, especially emergency situation for accidents. Thank you.
Thank you, Ahmed. I've got another. Sorry, go on.
Yeah, I think in addition to what Ahmed said, the ETS played a key role during the coronavirus epidemic, particularly when there were lots and lots of community case findings. And so the ambulances that were provided in PHC, played a very key role in being able to move cases, suspected cases from the communities or the PHCs to the testing sites, to the ambulatory care centers where they are waiting their results, and to some of the lab centers that were located in urban centers. So it bridged the gap between symptom manifestation, lab investigation, and then provision of care services. And that's a very key critical point, because coronavirus transmission could occur within a space of 5-10 minutes within the household. So if you're able to reduce, shorten the exposure time, it's really helped in curtailing the coronavirus pandemic. And I think this is a very big plus by learning the lesson learned during the pandemic. Thank you.
Thank you very much, Usman. And just touching on that point, the very valid point you made about ETS and how it is being used within COVID. When we were all having previous discussions before the webinar started, I can't remember who mentioned it, but I wrote it down that somebody said the need for ETS is more pronounced than ever due to lockdowns, and most other means of transport have stopped. ETS has relationships with health facilities and security forces which allow them to operate. I think that's a really valid point. I apologize, I can't remember who said it, but I wrote it down, and it just shows that ETS, and whatever form it takes with the NURTW or with the tricycles, that it's not a parallel system. It's very much part of the healthcare system. It contributes to the healthcare system. It's not a parallel system that should be used outside of the ministries of health, outside the health systems within the country. It should be there, and it should be looked at as a supporting entity. So thank you very much. Ahmed, there's a question here about, are there any plans for a national integration of the ETS database that can be easily accessed by all those working to implement ETS on different projects? Bit of a big question.
Yes. Actually, that is the overall aim in terms of creating visibility for the ETS. However, at the moment, it's at the level of ensuring state visibility across the states where ETS is being implemented. But I believe at the level of NURTW, who is actually the pioneer and the leader as a leading partner in the ETS, they already have their own database. However, it's actually not visible within the government institutions. And I think that is the aim, to ensure we bring visibility of ETS into government Ministry of Health, Federal Ministry of Health plans, and all other targeted intervention by the government. Thank you.
Thank you very much. We have a question here for IHP, so Usman or Cabo, either can jump in. The small proportion of ambulances still operational indicates, as you said, a lack of transport management and maintenance capacity at a primary healthcare level. As well, I assume a lack of access to centralized funds with which to carry out maintenance. Will this prompt a rethink as to whether primary healthcare facilities are the correct places to locate the ambulances?
Let me allow Kabu.
Okay, thank you so much, Osman. I believe that you can equally say something. So the question is whether the primary health care centers are the correct places to locate ambulances. Yes, they are correct places to locate ambulances. That is answer to that. However, now what strategies will be in place with a view to see that these ambulances are maintained? Because now in Nigeria, there is this kind of the strategy that each and every political ward is going to have one kind of focal primary healthcare centers, which a very kind of nice approach, a functional 247 that will cater for those population in that particular ward. And we do know that from those, there are very much remote areas wherever it is quite hard kind of to transport individuals from communities to facilities. So now ensuring that those ambulances are in the communities, in those primary care centers is quite important. However, what will be the mechanism that will be put in place to see that those ambulances are maintained? There's a transparency, there's accountability. The communities are kind of providing oversight to that. That is very important, but it is a correct place to have those ambulances. But the most important thing is the maintenance, the oversight, the monitoring, and also the assessment to ensure that they are doing what is expected. Because sometimes you can have ambulances at the primary health care centers that are not serving the actual purpose for conveying patients from communities to facilities. So there should be checks and balances. But if they will be there and they will be used correctly, that will go a great way in improving the access as well as the quality of services in the entire country. Thank you.
Perfect. Thank you very much. So, Usman, do you have anything to add, or are you okay if we move on?
Yeah, thank you, Edward. I think in addition to what Kawa has just said, if you look at the health system structure in Nigeria, it's a three-tiered health system. The PHCs are the closest to the communities. And so they have a very first contact with what is happening in the communities. And emergencies occur at the household level and those communities. So it's a very, very good strategy to have those ambulances located within PHCs, and they become part of the first responders in case of emergency. The other thing is that outside the ambulances located at PHCs, you could have a centralized maintenance and logistics system with a functional ICT, either as a toll-free line or as a CUG. Sokoto State has a closed user group. And so the response time, which, I mean, you can do an assessment to now find out set a limit for what response time you want to have, so that people from all the nooks and crannies of the communities, including hard to reach areas, can have a quick response to emergency situations, emergency pregnancies, or children who have really life-threatening situations. So again, the last thing is, now that they have procured the ambulances, because ambulances will not drive themselves, ambulances will not provide first aid support by themselves. Ambulances need to be driven by somebody. And so we now begin to engage constructively with government at the House of Assembly level to make dedicated budget line for emergency transport services. It's dawning on Nigerians now that as part of the health system, we begin to look at providing for emergency transport key. Outside the 7 pillars or thereabout, how can we begin to look at the effectiveness of the emergency transport as part of the pillars in the health system blocks? Thank you.
Thank you very much, Usman. In the interest of time, we'll go to 2 more questions, although there is a lot more. So Balogun, this one is for you, and if you could please keep your answer tight and to the point, that would be much appreciated. It is a very good question though. What would your recommendations be to a program just starting up with ETS?
Get to know the role of the NURTW. Get to know the communities. Get to know, because cultural differences from one state to the other, and political differences, the government is different, and so on. Get to know about the state or the community where you are going. Go through the steps that we had explained that time, the 8-7 different steps, beginning from situational analysis, you understand. Sustainability plan, it's very, very, very cool. If you are starting right from the word go, have within your mind that you're going to put up a sustainability plan. Even if you are spending 5 years on the program, right from day one, start thinking about sustainability plan. And ownership by key stakeholders, very, very vital. And sensitize these people, bring them into the board. But motivation of the drivers is also very, very important, because there is with high cost of maintaining vehicles, with financial challenges by drivers, there is usually so much dropouts nowadays. But if they are motivated, given refresher training and a couple of others, it will help a lot. Thank you very much.
Thank you very much, Balogun. So the very last question I will touch on. Can you please advise if some of the materials you mentioned can be accessed, for example, the training materials, logbooks, or technical briefs? Transaid's Knowledge Centre, which you can find on Transaid's website, is full of information about ETS, reports, technical briefs, the training manuals, examples of logbooks, etc. Everybody who has registered for the event today will receive a link to the Knowledge Centre, to Transaid's Knowledge Centre, where you can find all of this information, as well as everybody who is registered will receive a copy of the slide presentations and a recording of the event itself. So as I mentioned, if anybody would like to learn a bit more, they can go to Transaid's Knowledge Centre. So thank you very much, all of our presenters, Farouk, Ahmed, Ibrahim, Usman, Balogun. Thank you very much for your very interesting presentations on all the forms of ETS that are happening in Nigeria to all these different organizations. And it's very heartening to see how well it has been taken up from its start over a decade ago, and that people are continuing to use it, move it forward, innovate, change, make it better, try to get it into policies, working with the NURTW and other associations. It's all very heartening to see. And as somebody who's been going in and out of Nigeria for over a decade, great to see these improvements and the work that's going on by everybody to move the healthcare system forward in the country. So thank you very much. Thank you to all those who were able to attend today's webinar. Your presence and your questions have been much appreciated. Any questions that have not been answered, please don't worry. We have them all on record. We will go back and they will be sent to the people they are most relevant to, and they will be able to respond individually to the questions that have been sent out. So thank you for your participation. Thank you for your time. I hope the rest of your afternoon goes well. And thank you to all our wonderful panelists and for their fantastic presentations. Thank you and goodbye.
Thank you, Edward.
Well,
Thank you. Bye-bye.